I'm Aaryaman Sawhney. I am a current master's biomedical engineering student at Johns Hopkins this fall. So let me get started. So before I tell you what we're building, I want to start off by telling you something about the worst 2 days of my life. Um, so my father collapsed in India and he had neurocysticercosis, which was a parasite on the brain. And to be precise, no blood test would have handed us that diagnosis. What cost us days was everything around it. The workup was, scattered across separate buildings, every result on somebody else's schedule, and the delay was never the science, it was the logistics. Then when I moved to Austin, I started Accutane, which is very commonly a medication that you use for acne in your teenage years. Routine, monitored, and every month I drive to a lab, get stuck for a lipid panel and liver functions, wait, and then drive back to a doctor. 2 trips and a week for a question on a device on the counter that would have answered all those questions while I sat right there in the clinician's office. That's what a well-insured teenager in a major American city experienced. Then I moved to San Diego for college and I became an EMT and I worked at border clinics with Flying Samaritans. And I noticed the exact same pattern. 3 systems, one pattern. The test always existed. It was never where the patient was, unfortunately. So put yourself in the room. You have a febrile patient in December. Now, flu A, flu B, COVID, RSV, 4 different management decisions. 3 options. Order 4 separate tests, send it out, and the patient is admitted or discharged even before the results land, or treat empirically, which is what most of this room actually does, because the first 2 are always worse. Everyone is a workaround, and multiplex diagnostics solved this a decade ago. They're just not where the decisions get made, unfortunately. So why isn't it there? Not because multiplexing is hard. That chemistry was actually solved years ago. BioFire's film array runs a 20-plex respiratory panel, and it's excellent. It also, unfortunately, needs a $35,000 instrument and costs over $200 a cartridge. That's not a pricing decision, unfortunately. That's just the physics showing up on an invoice. And it needs a pump, a thermal cycler, and an optical train. And those 3 are why that box lives behind a lab door. We're not miniaturizing them, we're removing them. So here's what physically happens. A drop of the sample hits the inlet and picks up freeze-dried detection antibodies sitting dry in the channel. No pipetting and no cold chain. Capillary action, on the other hand, pulls it past all 4 zones. Nothing pushes it. The channel's geometry itself is our pump. Each zone has a different capture antibody bound to the electrode underneath. If the target's there, it gets sandwiched between the capture antibody below and the enzyme-labeled detection antibody above. This is a standard sandwich immunoassay, and I'm sure a lot of the physicians here have ordered a test that works this way. Here's a step that actually matters. That enzyme makes an electroactive product right at the electrode. Binding becomes current instead of color, which deletes the optical train, and the optics were most of the cost. 4 electrodes, 4 answers, and 1 channel. And to be precise, because it matters in about 30 seconds, this is 1 cartridge running 1 panel, 4 analytes. It is not 1 drop of blood answering every question in medicine. So obviously, now some of you have been waiting for this since I said cheap diagnostics from a startup. So let me get there first. 4 differences, all structural. 1, the claim is bounded. Theranos claimed 200 plus assays from 1 finger stick. That wasn't a business failure first. It was physically impossible. We claim 4 per cartridge at standard volume. 2, the method is public, 40-year-old peer-reviewed chemistry, and our patent discloses the entire architecture. Theranos' entire defense was that nobody was allowed to check. 3, the pathway is conventional, the 510K against cleared predicates. Theranos used self-certification to avoid exactly that review. 4, this is the one that hurts people the most, validation before deployment. Theranos put unvalidated assays in pharmacies serving real patients. Nothing we build will ever touch a patient and its decision until it clears independent validation. So Theranos was not a failure of point-of-care diagnostics. It was a failure of accountability. And the idea was never the problem. The refusal to be checked, in fact, was. And this, again, is a platform, not just a product. The architecture is analyte agnostic. The only thing that changes between panels is which capture antibody sits in each zone. Respiratory is first, but sepsis, cardiac, and metabolic run on the same cartridge and the same reader. So here are the economics and the number that I don't completely trust yet. So cartridge under $8 at volume. The target is around 25 against over 200. Bottom up, about 14,600 urgent care centers in the US, 10 panels a day, 180 days of the season, roughly 26 million cartridges a year, and about $660 million. Urgent care alone before we hit ER departments, the rural, and the EMS system. So where it matters isn't evenly distributed. Inside a hospital with a lab down the hall, this is a convenience. Outside that building, it's the difference between a decision and a guess. Pre-hospital, because that's where I come from. On a long transport, arriving with 4 analyte changes, the destination decision, and the pre-alert. Rural sends specimens out and waits days. And urgent care is the beachhead. 3 years as an EMT and in border clinics, so I'm not guessing, but I'm not assuming I remember it correctly either, which is why the ask at the end of this talk is to be able to get in a room with you guys and talk and take this further. And it's not just money. So as this is an AI conference, let me be specific about where AI belongs and where it doesn't. So the reader outputs a current versus time curve at each electrode. The curve shape tells you whether that's true binding event or just a bubble. Second, the EMR, and it runs both ways. Outbound is the easy half, and inbound is the interesting one. The chart already knows this patient, comorbidities, immunization status, medications, priors. So the model isn't reasoning from 4 numbers in a vacuum. A raw positive data. It is a raw positive data. A positive read against that history is a recommendation. And the hard part is the longitudinal record, which already exists within the EMR system. But it would be very easy for me to stand here and say the word AI 40 times. The AI is not what makes the test work. The chemistry is what makes the tests work. The AI is what makes 1,000 tests worth more than 1,000 results. So where we actually are right now, we have a patent filed, our company is incorporated, the cartridge is designed, mold printed, and casted, and we've applied to the Johns Hopkins Venture Fund for the Fall Accelerator. And here's the other column on the screen on purpose. We don't have our antibody zones functionalized yet, and there is no end-to-end run, so no sensitivity data. There's no clinical validation or FDA submission or revenue or capital. From here, our goal is to functionalize, build the first reader, do clinical validation, and then approach the 510K against cleared predicates. Now, the benchwork, a clinical partner, and time. No scientific merit, again, in this world is required, which is not the same. Hopkins gives me the wet lab, and the venture fund gives me the commercial half. I'm not doing this just from a garage as I previously was for the last few months. So I know that there are investors in this room. So let me be clear what I'm asking for. And it isn't just money. 3 things. I'd rather leave with any of these than a term sheet and money. If you order these tests in emergency departments and urgent cares and community clinics, I would just like 20 minutes to be told where I'm wrong about my workflow, not a demo, just an interview. Second, a clinical validation partner. The 510K study needs an institution and a physician and a co-investigator, and that's not something I can buy. Third, anyone who's taken class 2 devices through the 510K. 1 hour with you for me right now is worth more than just a term sheet. So I started by telling a story about my family. But that's still the whole problem. Not what we can't detect. It's not that we can't detect these things. It's that detection lies in building where the patient is actually standing. So thank you, and I'm ready to take any questions.
Thank you so much. So we'll open it up for the judges.
Who else is working with you on this process or this product?
So currently, I'm the sole founder.
Not a product.
I'm sorry?
I'm sorry, it's not a product, it's a platform.
Right. So I'm currently the sole founder and talk with multiple co-investigators and PIs throughout the Johns Hopkins research community, as well as the Johns Hopkins Venture Fund, who are going to help me take this product to a finished, reader, as well as being able to clinically validate it and run it in the labs.
Any idea what the 510(k) process would cost?
At the moment, we're probably looking at close to $50,000 as an initial 510(k) pathway. So the initial cost of just making this device right off the bat is the raw materials, all inclusive, is about $5,000. But actually approaching the 510(k) pathway eventually, we put it in the ballpark of $50,000 minimum.